In my personal opinion, we're entering the era of geographic atrophy, with several new potential therapies about to be available. We really need to begin understanding how to optimize selection of candidates for those both present, depending on the countries, and future therapies. These are my financial disclosures, but obviously they have nothing relevant to do with the content that I will share with you for the next few minutes. Firstly, it doesn't matter if the patient usually comes to our clinic alone. He has caregivers, he has relatives, she has family, and we need all of them to be on board with the decision making because they need to be included in a very hopefully long process with continuous delivery of treatments which have been proved to be the best possible option because with all these therapies, the longer that we are administering them, the better the outcome is. So we need to have on board everybody related to this process. And also we need to really understand the patient's preferences and the motivation to retain vision. We know patients are completely different, and we also need to understand each one of them as an individual in order to make our offer in terms of treatment more accurate. In addition to this, remember that the AREDS study showed a significant decrease in the centripetal progression of the atrophy. So, in every single case with geographic atrophy, mostly in extrafoveal lesions, we need to establish our recommendation very clear because this is perfectly available treatment, and with this formula, about 30 to 50% of decrease in the centripetal progression of the geographic atrophy can be achieved with this vitamin supplementation. Then we need to analyze by multimodal imaging different insights into the particular case that we are facing. So we can analyze several findings related to GA lesions and also findings related to the environment surrounding that geographic atrophy lesion. We all recognize this RP atrophy, this geographic atrophy lesion here in the blue autofluorescence, but we know more than that. It's not only the diagnosis itself, but it's to individualize our criteria based on four main items: focality, circularity index location, and borders. So we have this patient at baseline, multifocal lesion, extrafoveal location with hyperautofluorescence of the extrafoveal borders, distal borders from the fovea, and a relatively low circularity index. So after 19 months of follow-up, the visual acuity is somehow stable with centripetal progression of the atrophy. So by autofluorescence, we can assess if the lesion is multifocal, if the lesion has low circularity index, if the lesion has an extrafoveal location, and if the lesion has hyperautofluorescence borders. All these four are signs associated with rapid progression. Whereas, on the other hand, unifocal lesions, high circularity index lesions, lesions located fovally, and GA lesions with no hyperautofluorescence in the borders tend to progress more slowly. Also, differential diagnosis is key. All these cases show macular atrophy, but none of them represents atrophy secondary to AMD. We see a myriad of possible diagnoses, mostly achieved with autofluorescence. So our autofluorescence device is extremely helpful to this differential diagnosis. And we were talking about the borders, and the group of Frank Holzis from Bonn a long time ago proved that the presence of hyperautofluorescence and the quality of that hyperautofluorescence at the border is key to identify bad or worse prognosis in patients with geographic atrophy. And remember that GA is not a primary RP disease. Before that, with the macular environment as represented by the different type of drusen and deposits, we can really understand the potential prognosis of a particular case. So we need to be keen in our observations to differentiate soft drusen, reticular drusen, cuticulaire drusen, and other deposits. Beginning with soft drusen, we know that these are the hallmark, one of the main hallmark features of AMD. However, in the presence of atrophy, soft drusen tend to be associated with less rapidly progressive lesions. So they are somehow, if I can say, overrated because of this. However, we have a clear underrated deposit. We need to recognize reticular drusen because these lesions are associated with multifocal development of GA and a very rapid progression. Finally, cuticular drusen are the cheating drusen. We usually tend to think that they are benign, but as Dr. Janussi's group published, almost 40% of patients may eventually develop GA or neovascularization. So they are not benign at all. Look at this picture because this is clearly an underrated finding in our patients with AMD. We see a wide double layer sign with elevation of the RPE. We see the Brooks membrane entirely from one side to the other of this B scan. This corresponds to basal lamina deposits. And basal lamina deposits, again, as we can identify here with this double layer sign, are absolutely related to the geographic area where the atrophy will develop and progress. Look at this image, for example, here. Geographic atrophy, extrafocal location, multifocal location, low circularity index, and we see how in less than 2 years there is a significant growth and progression of the lesions demarcated by the area where those basal lamina deposits were. So to our summary, we need to add reticular drusen or basal lamina deposits are high-risk findings for GA development and progression, whereas soft drusen and cuticular drusen tend to progress less rapidly. And when analyzing patients with atrophy, we need to recognize the masqueraders for both neovascularization and exudation. Do you think this represents an exudative sign? it doesn't. This corresponds to degenerative pseudocysts. And what about this? This presence of subretinal hyperreflective material is very frequent in a lot of patients with geographic atrophy. And we call this autoretinal degradation because the progressive degradation of photoreceptors and eventually later RPE makes sometimes difficult to recognize if that is exudation or the neurodegenerative process itself. Let's take a look at this right eye with geographic atrophy, apparently with foveal involvement. But the structural OCT shows there is no foveal involvement. Also, we see some degree of double layer sign in the perifoveal region. We see the volume scan showing extensive basal lamina deposits with cirrhosa, and eventually we see those hyperreflective subretinal materials around the fovea. But the OCTA failed to prove the presence of any neovascular lesions or even flow signal at the level of those deposits that may eventually correspond to the degenerative process of GA. Another illustrative case, both eyes, and you can see again subretinal hyperreflective material. But again, the OCTA shows no evidence of neovascular lesions. So this autoretinal degradation is challenging in terms of the differential diagnosis between neurodegeneration and exudation. Again, we see the volume scan, in this case extensive basal lamina deposits, and we see how as they fade away eventually we can still observe the hyperreflective material contained in that double layer sign. Obviously, there is no evidence of macular hemorrhages in that eye. And what about the fellow eye? Again, extensive basal lamina deposits, cirrhosa lesions, and again, extensive subretinal hyperreflective material that could possibly lead us to think wrongly that there is exudation due to macular neovascularization. The color photograph, the autofluorescence, there is no evidence of macular hemorrhages or exudation in them. So let's take a look at this peculiar finding too, right here. That's not subretinal fluid. That corresponds to persistent basal lamina deposits, as beautifully illustrated by Dr. Christine Kirsch's group. We know the histopathological correlation of this finding, and this does not represent exudation ever. We need to recognize it in order to avoid unnecessary interventions. And this hyperreflective space within that hyperreflective subretinal material is typical for partial resorption of the acquired vitelliform lesions content. We know that these lesions tend to progress to collapse, catch-up phenomenon of the lipofuscin content of them, and eventual development of atrophy. So there is no neovascularization here, there's no neovascular tissue. This is the behavior of the acquired vitelliform lesions, these hyperreflective subretinal materials that can at times look partially resorbed and then leave this hyperreflective appearance in the structural OCT. There is no evidence of flow signal or neovascular tissue related to this. And these oval-shaped, perfectly well delineated RP lesions that correlate with this peculiar appearance in the structural OCT correspond to retinal pigment epithelium apertures. Again, this is not exudation, there is no neovascular tissue here. This is called RP apertures, typical for drusenoid pigment epithelial detachments as well as within the spectrum of chronic CSC. So when analyzing patients with GA, we may eventually see exudation masqueraders such as pseudo-degenerative pseudocysts, outer retinal degradations with hyperreflective subretinal material acquired by telephone lesions, and these RP apertures. But we may also find neovascularization masqueraders. We see three very similar images: double layer sign, shallow irregular RP elevation, but the OCT shows neovascular tissue in the first two, but not in the bottom one. So the first image corresponds to an exudative neovascular type 1 neovascular AMD needing injection. The middle one is a non-exudative neovascular macular neovascularization. Only observation is needed. And finally, again, we see those basal lamina deposits with hyperreflective subretinal material. Observation, no need for treatment. Once again, let's take a close look to basal lamina deposits with the typical and beautiful histopathologic correlation provided by Dr. Christine Curcio and her group. And these, again, are findings that we want to make sure that we observe, report to patients, and we perform the close follow-up in order to really be accurate in terms of the development and progression of geographic atrophy. Here we see a typical predominantly serous PED in the setting of neovascular AMD. This is a typical fibrovascular PED, again neovascular AMD. But this is still the leading cause for unnecessary intravitreal injections administration. This is a drusenoid pigment epithelial detachment and is structurally different to any other form of PED. So, whereas injections are needed in patients with fibrovascular or serous PEDs associated with neovascularization, there is no reason to administer intravitreal injections to drusenoid PEDs. Although soft drusen may eventually coalesce, leading to later development of drusenoid pigment epithelial detachments, the RP dysfunction can also be associated with the presence of subretinal fluid, both high density and low density. As we can see here, subretinal hyperreflective material related to neurodegeneration, but not exudation, because there is no evidence of neovascular tissue or flow signal in these lesions. Remember that the drusenoid PED have a biological grow phase followed by sudden collapse and reabsorption of the material, leading to foveal center. If the drusenoid PED is located fovally, foveal center development of geographic atrophy. So this is high-density subretinal fluid related to exudation from neovascularization. This is an acquired by telephone lesion, and although they are located subretinally, they represent very different things. We need to inject these patients, but we need to observe acquired by telephone lesions. This is no neovascularization. And finally, we see here calcified soft drusen geographic atrophy that we will better see here in the out of fluorescence, and Here's the fluorescent angiogram showing a very typical hyperfluorescence parafoveal lesion, which in the OCT appears as a mild microaneurysm, with or without exudation. Again, the OCTA shows that there is flow signal within this tubular aneurysmal lesion, which is called PVAC, parafoveal vascular anomalous complex. And it's not infrequent to find this in patients with geographic atrophy. Here we can see another example where the patient shows, associated with the GA, this aneurysmal isolated lesion, in this case with exudation, a PVAC. So to finalize, we can also see neovascularization masqueraders, including basolamina deposits, drusenoid pigment epithelial detachments acquired by telephone lesions, and these very interesting PVAC lesions. So thank you very much for your attention. And to end this video, please remember that patients have a follow-up time, and we need to identify and project the geographic atrophy in that period of time. So we know this looks like a banal, almost banal finding, very small GA lesions, but the patient will come to us on a 4 or 6 monthly basis, and we will see how this GA behaves. We are able to identify early changes to predict the prognosis, and hopefully in the very near future to identify our best candidate patients for future GA therapies. Thank you.